Welcome back, everyone, for our next conversation in patient blood management. I want to just remind our audience that patient blood management is a patient-centered, organized approach in which the entire healthcare team coordinates and makes efforts to improve and manage and preserve a patient's own blood. That's what we're talking about today. And one of the key pillars, managing and identifying anemia, which is a low blood count, and addressing it appropriately. And so today we are very excited to have a leader, Dr. Stephen Frank from Johns Hopkins in Boston. Their formal patient blood management program began in 2012 and has had great success. I will link some website information because I feel that Johns Hopkins has a great public-facing education and awareness centered around transfusion alternatives, informed choice, information that's vastly educational to the public. Dr. Stephen Frank, welcome to our podcast.
Thank you, Sarah. I'm privileged to be your guest today. I hope everybody learns something.
Hi, and welcome, Dr. Frank. Let me give a little introduction to our listeners about you. Dr. Frank is a professor in the Department of Anesthesiology and Critical Care Medicine at the Johns Hopkins Medical Institutions. He's the medical director for the Health System Patient Blood Management Program and for the Center for Bloodless Medicine and Surgery, a program for patients who wish to avoid transfusion or cannot receive transfusion. He's currently on the editorial boards for the journals Transfusion and Anesthesia and Analgesia, and he's served on the board of directors for AABB and the Society for the Advancement of Patient Blood Management. He's also been the chair of the Patient Blood Management Committee for the American Society of Anesthesiologists. He's a member of the Miller-Coulson Academy of Clinical Excellence and has earned the Distinguished Teaching Award from the medical students at Johns Hopkins. So what an honor to have you with us here today. Thank you so much for your time.
Sure thing, Marianne. I'm privileged to be your guest today.
We wanted to talk today about this article that Dr. Farmer had made us aware of, a propensity-matched cohort study of intravenous iron versus red cell transfusion for preoperative iron-deficiency anemia. Dr. Frank, why don't you explain this article for us and tell us what this is about?
Sure, Marianne. So there is a database, a national registry database called Trinetics that has over 200 million patient records in it. The patients are gathered from insurance claims and Medicare databases. And this database is incredibly granular with a lot of detail. So I was working with one of our superstar medical students, Una Choi, who's the first author, and she mastered the use of this database. The hypothesis we were testing is that iron-deficient patients would benefit more from intravenous iron infusions than they would from red blood cell transfusions before surgery. Lo and behold, that's exactly what we found. The patients did better showing up with their own red blood cells that are enhanced, of course, by giving pre-op iron treatments than they did requiring someone else's red blood cells from the blood bank. It just makes sense if you think about it. Showing up for surgery with your own red blood cells seems like it should be better than getting transfused with someone else's. And I'll leave it at that, and then we'll go into more detail.
Yeah, I noticed. So 30 to 50%, the article stated, patients present for a surgery in a anemic state or a lower than normal blood count. And many of those have iron deficiency. So in the study, there was two groups. One group, that iron deficiency and anemia was identified, and they were treated with blood replacement. So donor blood was given to them, a couple of red blood cell units, whatever they needed, and then they moved to surgery. The second group was given IV iron replacement and no red blood cells. Can we talk a little bit about the rationale for a clinician? Why would a clinician decide to treat anemia before surgery with red blood cells?
Sure thing, Sarah. So for years and years, that's been the default treatment for anemia, especially in patients having surgery, and that is red blood cell transfusion. It's only in the last maybe 10 or 20 years that iron replacement has become more of a topic for discussion, and even a topic that's been implemented across healthcare systems. Although it's a slow uptake giving iron before surgery because a lot of places haven't figured out how to do it yet. In other words, someone has to see these patients, someone has to diagnose the cause for their anemia, someone has to order the iron infusion. There's got to be a place where it's given, okay? Often there's insurance approval ahead of time. Even then, not all insurance companies will reimburse for IV iron. They want you to fail oral iron first before they'll pay for intravenous iron. So it's not as easy as it sounds. But if you do it properly, it's good for the patient, it's good for the system, and you can reduce unnecessary transfusions.
So from a surgeon's point of view, I can see where ordering a red blood cell unit or two, fixing a kind of a quick expedited service to surgery makes sense. The process seems a little bit laborious in managing it a different way. So what would be the rationale of a surgeon today that says, I'm going to treat this iron deficiency with IV iron replacement instead of the quick fix of red blood cells?
Yeah. So the first challenge to make that happen is you need your preoperative labs drawn between 4 and 6 weeks before the surgery if you're going to have time to treat anemia. Often labs are drawn, even in our institution, 3 days before the surgery. Okay? So unless you're willing to postpone the surgery to treat the anemia, 3 days is not enough. For elective surgeries, especially patients like hysterectomy or myomectomy for heavy menstrual bleeding, those are very elective procedures. So you have time to diagnose and treat anemia ahead of time. Those are not emergency surgeries. The same with joint replacements, like hip and knee replacements, which happen to be the most common surgery in America now, if you don't include cataracts and C-sections. Joint replacements are the number one surgery in America, which is not surprising because we all have 4 joints, hips and knees, and we're all living longer, healthier lives, so we're wearing out our joints. And those are another elective type of surgery where you can have plenty of time to manage anemia before surgery. Basically, in the study, we showed that it was a propensity-matched risk adjustment for all the potential confounding variables. We found that the patients who had intravenous iron infusions had less mortality by 37% and less morbidity by 24%. And by morbidity, we mean blood clots, infections, heart attack, stroke, respiratory failure, and renal failure. So less morbidity, less mortality, and they had less lower incidence of blood transfusions, almost a 3-fold decrease in the requirement for transfusions, higher hemoglobin levels by almost 1 gram.
That's pretty interesting that a month after surgery, I believe it was, and tell me if I'm not speaking to the study correctly, but the actual hemoglobin of the patients who were infused with iron, given IV iron replacement, they had a higher hemoglobin level than those where we gave them donor blood. So showing the much improved therapy to just giving the patient what it needs to build their own healthy blood.
So yeah, the patients in the iron infusion group had a hemoglobin just above 10 coming into surgery, whereas the patients in the transfusion group were at 9.4. It's a win all around. Higher hemoglobin, less transfusion, and better outcomes. If we could just figure out an easier way to get iron into patients before surgery, and including whose job is that, okay?
Right.
Because, anesthesia doesn't always want to own the pre-op treatment of patients. Surgeons don't always manage pre-op medical problems like iron-deficient anemia. And then it comes down to hematologists or internal medicine doctors. And most patients are pre-op assessed by internal medicine doctors.
Yes.
And some of them are interested in treating iron deficiency, and some of them would rather refer to a hematologist.
Let's talk about some of the challenges. We decide it is better for the patient outcomes. Mortality is less, the morbidity is less complications. So we really want to treat these patients before surgery, and we have these challenges that we've discussed. What are some of the answers or the solutions that healthcare organizations can use to meet those challenges?
Well, some places have done business plans to treat pre-op anemia with iron replacement. And if you do it properly, for example, at NYU and at Duke Medical Center, to some extent at Johns Hopkins, they've figured out how to do this to give IV iron before surgery to make it work financially and so the hospital is reimbursed and the patient is treated with iron instead of blood transfusions. And it comes down, like you said, to getting a spot in the infusion clinic and how long they have to be at the infusion clinic. Some of the iron preparations can be given faster than others.
Mm-hmm.
We tend to give iron dextran because it's a lot less expensive than, say, ferret carboxymaltose. But we still think the cost benefit is better because it depends what reimbursement model you're under.
Dr. Frank, I want to ask you, what about patients when you're discussing this with patients? This could be any provider, yourself or any provider. Do you feel that patients have a little pushback when you're discussing IV iron versus red blood cells? I think a lot of the public is so much more comfortable with hearing red blood cells save lives, and they think, what is this IV iron? Have you ever heard that from patients?
Oh, good question. Yeah, you see the Red Cross advertisements, give blood, save a life, right?
Right.
We have those signs in our elevators right now.
Mm-hmm.
Yeah. That being said, okay, it's kind of like the analogy would be the cell saver, okay? I haven't met a patient that wouldn't rather have their own blood back. I'd say it is a new concept for a lot of patients. And then there's always a question of whether they should take oral iron replacement instead of intravenous.
Right.
So I have a slide in my lecture that says $4 worth of iron tablets can avoid $400 worth of blood transfusions.
Mm-hmm.
So the problem with oral iron is it's very slowly absorbed. Only about 10 to 15%
Mm-hmm.
of oral iron is absorbed into the bloodstream. So it takes sometimes 4 to 6 weeks to see any benefit
Mm-hmm.
of oral iron. But I wouldn't give up on oral iron because, for example, when we look at blood donors who donate blood, often oral iron really works to bring their hemoglobin back to normal faster. So compared to no treatment, oral iron is definitely better.
Yeah, and I hear you saying that there's different types of IV iron that you really have to be knowledgeable and consider the cost to the hospital, the cost to the patient, how long it's going to take in the chair. And there's also different kinds of oral iron, right? There's ferrogluconate, sucrosomial iron. There's a lot of different types of iron, and cost becomes a factor then too. So you really have to zone in on that individual patient, right? And see what their need is and how long they have before the surgery or what have you to treat.
Yeah, I remember one discussion we had with Dr. Manny Munez, who said sometimes you can give them maybe you can get them into the infusion chair once and give them a dose of IV iron and then sucrosomial iron to back it up that will help kind of prepare them for their surgery. So, even if you can reduce the amount of infusion chair time that you need. So, some of those are good solutions to try to figure out what will work best. But we obviously know that treating the iron deficiency and the anemia is superior, according to your study. So that's pretty exciting news. And then the role of a comprehensive patient blood management program. We know Johns Hopkins has led that. In the literature, they've been very open about the success of developing for an organization a comprehensive patient blood management program. So, beyond the surgery, what can we do if this patient is in our hospital? What ways can we help them if we have an organization that has a structured patient blood management program and a multidisciplinary team that are all addressing the needs of the patient's blood?
All right, sure thing. Since 2012, we've been running 2 programs side by side. One is the patient blood management program, and the other is the bloodless medicine and surgery program. And they share a whole lot in common. For example, treating iron deficiency before surgery is not just good for Jehovah's Witness patients, it's good for all patients.
Yes.
But other blood conservation methods, such as using the cell saver during surgery, keeping patients warm during surgery so they bleed less, using tranexamic acid, for example, has been called a game changer in blood conservation. These methods are good for everyone. And so what's normal routine practice for Jehovah's Witness patients is now spilling over into the general population. And so we're saving blood on all patients. Using smaller phlebotomy tubes, for example, in the ICUs especially, where patients lose about 1% of their blood every day just due to lab testing, we've made a difference across the board with our comprehensive patient blood management program. And the most recent analysis that we did shows that for every dollar we spend on our patient blood management program, we save $7.50 in return. So it's a huge return on investment. So it's good for the hospital, good for the patient, and everyone wins.
Yeah, I really thank you for the article that you published in 2017. And I'm going to link it to this podcast so that if any organization is considering implementing a patient blood management program in their healthcare system, it gives nice steps and how you decided to implement patient blood management, and then a lot of the positive results that you had from that. And I would love to see an update of that article, because I know that as we get better educated and staff become more, well aware, a lot of times our return on investment and our patient outcomes just keep improving. But I would encourage anyone to read that article on how to implement a patient blood management program.
Yeah, one thing that we've shown in that paper and since then as well is it's not just all about red blood cells, because, for example, we spend as much money on platelets at Johns Hopkins as we do on red blood cells. We spend about $1 million a month on red blood cells and about $1 million a month on platelets. We've shifted some of our focus towards what we call the yellow products, which would be plasma, platelets, and cryoprecipitate, because a lot of PBM programs, patient blood management programs, they focus on red blood cells because that's kind of easy. You've got a hemoglobin trigger for a metric. But when you talk about plasma, platelets, and cryo, there's a lot of unnecessary transfusions going on there and a lot of blood and money to be saved. And if you can reduce unnecessary transfusions of the yellow products, you're also improving outcomes. For example, trally and taco
Right.
are every bit as common with the yellow products as they are with red blood cells.
Yeah. And so for those who may not know what trolley and taco is, we're talking about an acute lung injury due to the transfusion of those yellow products. And then taco is a circulatory overload, just so that we kind of understand what sometimes our terminology is. This has been a very enlightening discussion, Dr. Frank. When you think about what message you would like the audience to take away, what would you like to say to both medical professionals and also the lay public about your study and what your researchers found?
Sure. I mean, this study is a database analysis, retrospective, but nonetheless, we think it provides solid evidence that treating iron deficiency with iron before surgery is a better way of managing anemia than treating patients with transfusions. It also makes sense that you should show up for surgery with enough of your own red blood cells than requiring someone else's. For example, when I donate blood, I take iron tablets because you recover your hemoglobin faster. And there's a randomized trial showing that you recover your hemoglobin in 30 days when you take iron tablets after a blood donation, as opposed to 150 days if you don't take iron tablets.
Oh, okay.
So even oral iron is effective, but often before surgery, we're pressed for time.
Right.
And that's why most places will recommend intravenous iron, because you can give a much higher dose in a much shorter time period. Oral iron is a whole science in itself. Some studies suggest we should take oral iron every other day rather than every day. because of hepcidin levels. Hepcidin blocks iron uptake. In other words, if you take iron every other day for a month, that's probably as good or better than taking it every day, because the absorption is equal and the side effects are less. And I've been taking it for years. Not only when I donate blood, but I'm a runner and I like to have my hemoglobin up to a normal level. And a lot of runners run low hemoglobins.
Sure.
So if I'm training for a marathon, I'm often taking oral iron and even B12 and folate to keep my hemoglobin up where I want it to be, so I can carry enough oxygen to make it through these races.
Fantastic. Thank you so much for joining us today. It was a great conversation. Thanks for all the great work you're doing in patient blood management.
Well, it's my privilege, Sarah and Marianne. Thanks for having me as your guest today, and I hope to see you down the road.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.